Hi everyone, and thank you for tuning in. I'm Dr Zoe Williams and you're listening to the Visionable podcast, the show that shares the views and perspectives of leading minds in healthcare. In each episode, I'll be interviewing leaders and experts from across the health and care landscape, discussing their thoughts on the most pressing topics in the sector right now and future innovations. Today we're talking about the future of emergency care with paramedic David Davis. David works in a number of roles, including as an operational paramedic, clinical director in mental health commissioning, and as a spokesperson for his profession, as well as being involved in a number of projects such as pre-hospital stroke training in Europe. Previously, he's led a national workforce programme in NHS England and Health Education England, been mental health lead for the College of Paramedics and undertaken a number of leadership roles in digital healthcare, having recently graduated with an MSc from the NHS Digital Academy. Thank you for joining me today, David.
Good to see you.
Gosh, that's quite a diverse range of things that you're involved in.
What can I say? I like being busy, but I'm also excited that it means that being a paramedic today means that you can do a lot more than what people perhaps would think of the traditional role as a paramedic in the back of an ambulance. I love doing that, but I also like doing the other stuff too.
Yeah, I think it's the same with general practice.
For sure.
Actually, it kind of so the work you can be involved in is so diverse and far-reaching. And what's great about it is that clearly reading that, it's easy to identify the things that you have a genuine passion in, and that's why you've been drawn into it. So the mental health side of things and the commissioning and the leadership stuff.
I guess I know we're going to be talking about digital stuff here today, and I think that it's really important to remember the role of professionals and how they work today when thinking about how digital technology can support them. There's some really exciting opportunities to make work life better, more rewarding, and I guess keep people in the profession longer. I
think that's the thing we must never forget when we're talking about a huge structure like the NHS is, the thing that holds it up is the people that
Sure.
work in it, and we can never forget about them. Which kind of leads me on to my first question really, which is, can you tell us a bit about your current experience of working in emergency care in the UK right now? And that's, I guess, both about the system and the people working in it.
Yeah, I work on an ambulance a couple of times a month, and I live in awe and respect of my colleagues and my mentors and my friends who still work every day, well not every day, but every week as frontline operational clinicians. And I recognise that I'm super privileged to A, be able to still do it, but B, have diversity in the work that I do. For them, and when I'm working on those shifts, it's harder than it used to be. I mean, things have changed over the 20 plus years since I've been doing it. At the beginning, the work was very much as you might have thought of typical 999 call work, people having heart attacks, people having crashes in their cars, and picking up people who've fallen over. Following the 2003 reconfiguration of primary care, the work of a paramedic is very, very similar oftentimes to that of GPs like you. And we see the same patients, perhaps presenting at a different time with different acuity, but consistently over the last 20 years, the demand has grown, and grown both in terms of total numbers, but in scope of the work. So mental health is something that people have to work with every day, exacerbation of long-term conditions, and that just means it's busier. But I was reflecting, before I came here today, that when I do my operational shifts, I see less heart attacks, less strokes, and less of other disease, and that's because medicine has improved and the care that people get is working. But, and it is a but, it's really incredibly busy. And busy means different things for different people, but typical shift on an ambulance for me is one where the meal break comes because you reach the end of the meal break window, and depending where you work, you have to have a meal break. And when I was in my 20s, I felt like I didn't ever need a meal break. Now I'm approaching 50. I really do need that 20 minutes to have a sandwich and some water because you need that to be able to sustain you.
Yeah.
You spend hours waiting to hand over in EDs.
Yeah.
You spend hours waiting to get through to GPs like you on the phone.
Yeah.
And you found yourself working, doing a kind of coordinating role, trying to help navigate people to the care that they need.
It sounds, and it's the same, I think, for us as GPs, the job has just got much more complex, and the boundaries around what your job used to be are constantly extending and extending and extending. What's the general feeling amongst the paramedic and ambulance service workforce right now?
Yeah, I don't think you can say there is a general feeling. I mean, one of the things that we've seen over the last 20 years is a massive increase in the number of paramedics, but that's always falling short of the demand for the profession. And the demand for the profession isn't just 999 calls, it's primary care practice, GP practices wanting to recruit paramedics or go off and work in mental health commissioning like I have. And so, you know, the supply of paramedics can't meet demand. But things have also fundamentally shifted in terms of career aspirations for the profession. I think when I started in the ambulance service, I thought that I would be there until I was 68. That wasn't quite to be, but certainly there were a majority of lifers or people who joined the profession, whether it be their first profession or second profession, and planned to be there till retirement, and still are. That isn't the case for people graduating in paramedic science today.
Yeah.
Actually, they say that they're more likely to last 5 to 7 years in an ambulance, after which time they'll be seeking other opportunities.
Right. And you've already spoken about some of the challenges that first responders face on the ground, turning up to hospital to hand a patient over and being in that queue and, trying to liaise with GPs, and, the GP workforce is under pressure, so that's becoming more and more difficult. And I imagine also actually paramedics find themselves doing what they would think to be work of GPs because patients are finding it more and more difficult to access their GP. And, what can they do if they're struggling? The next thing they might do is call for an ambulance. What are some of the other pressures that first responders are experiencing out there on the ground?
Where do you start? I mean, I think probably starting saying that working as a healthcare professional, wherever you work, still feels like a privilege and a wonderful vocation. And I know for the vast majority of my colleagues, and certainly I feel that way. So to pile up the negatives feels slightly disingenuous, but it is the case.
It's a big but though, isn't it?
And it is a big but. It's the relentless nature.
Yeah.
And again, I recognise, as compared to you, when I work in an ambulance, I only see 3 or 4, maybe 5 patients in a shift. It's ridiculously poor use of my time when I know that you're probably seeing 60, something like that. But it is a relentless nature of it. Then there's the impact of constantly not knowing what you're going into, and the effect that has on people. Becoming adrenaline addicts over the years has an effect on you and your mental health and well-being. And then there's the reality that, and I'll talk about suicide as an example. I've lost count of the number of people I've been to care for who've either died by suicide or we've had to look after them. And that's an example of the, what do they call it? Trauma or moral injury or stuff that you have to experience. Now, that doesn't affect everyone. They don't care, doesn't affect everyone, but different things affect different people.
Yeah.
And there's no question about the fact that my profession and my colleagues that work in that space see some of the most horrific stuff that there is to see.
And I think when you say that, if you were to ask somebody, do you think that working as a paramedic or an ambulance is stressful? A lot of people say, yeah, I couldn't do it. I couldn't deal with the blood. I couldn't deal with, a pile up on the motorway where there are lots of people severely injured. But that's not the stuff that really is the trauma that people take away with them, is it? I mean, for some people it might be, but when you work in your profession, what are the things that actually do affect a person's mental health when they're working as a first responder?
If I knew the answer to that, I'd be able to help so many colleagues. But we believe that you're right, there'll be some cases in some instances that either a single one or a collection of similar ones, or something that perhaps resonates with you, perhaps the death of a child if you've experienced that, or an elderly relative, which will cause you particular trauma, and perhaps you'll land up with PTSD or anxiety problems or worse. But there are a number of us who think that the fact that there isn't an ability to have time out, and the kind of relentless nature, combined with the pressure from the system, and this is not criticising the system, the pressure comes internally as well, because you want to help as many people, but things like standing for 4.5 hours, 12 hours sometimes, to hand over a patient in the corridor of an emergency department is profoundly unpleasant. For a number of reasons. Your patient's not getting the care they need. You feel worthless because you can't add any value to anyone, and you know that there are people who could be your grandmother or your mother laying on the floor unable to be picked up because the ambulance can't get there. You see your colleagues in the emergency department absolutely exhausted, and you get a sense of it really kind of, well, it does for me, I'll speak for myself, it really jars. And when that's piling up, it means that you're more susceptible to the other stuff. Again, I reflect on the fact that I'm super lucky, I've got a portfolio career, which means that I just stand in amazement and honour of my colleagues and friends who do it every day and look at their personal resilience and think it's incredible. But as a profession, we didn't have conversations about personal resilience, professional resilience. We haven't done the investment in how we keep ourselves well and safe, whether that's through sport, meditation, exercise. I don't know, we just didn't, we've never planned for that. So these things need to happen now, needs to happen with the undergraduate population, and it needs to be supported by organisations too.
Do you know, there's one point in my career as a doctor where I did see that done well. It was for a very short period, and it was actually when I went to work at the Nightingale Hospital in London, when that opened for a short period. And the training to work there was short. It was a 12-hour training session, and a significant proportion of that training was around how to look after yourself and to look after your colleagues. And it was just a completely different mentality to what I've ever experienced any other time working in the NHS. It was actually, if somebody does it, because we had to learn a bit of sign language as well because of the environment, and as if somebody takes time out, we celebrate that. We celebrate that that person is recognised, and we support them, and we make that happen because that's priority. And any other time in my medical career, I think, taking a time out is a bit like, what a loser. So it definitely needs to change, because the job has changed significantly, the pressures have changed, and if we don't look after our workforce, we're already seeing the fallout of that. We're seeing, people retiring earlier than they planned to. Like you and I, our clinical hours, because we have other interests, but a lot of people are just reducing their clinical hours. I see this in my GP colleagues all the time, because they need to do that in order to preserve themselves. And we're starting to see new workforce crises purely because people aren't able to look after themselves and work the hours they used to work.
That's right. And no one likes to talk about COVID, because you're not meant to talk about it anymore because we're living with COVID, and that's true. But the stress and strains of COVID on people working in emergency care have been dark and profound. We've lost colleagues, been to their funerals when we couldn't even go to the funerals of our own family, and seen people dying in droves. This stuff lingers, but you're right, we do definitely need to do things differently. We need to look after people. One of the things that's particularly important is safety, and I think that when people are taking on high levels of risk and complexity in their clinical practice, we need to work out how we can support them to make better, effective clinical decisions where they're as safe as possible. They protect individuals, because all of us have an unreasonable scope and breadth of practice to be able to practice safely within, experiencing stuff that you might see once every 10 years. I've never, for example, maybe once in 20 years dealt with a mother who with a shoulder dystocia, for example, in delivery, but I could tomorrow be expected to deal with it. And how do we look to keep people safe? And historically, in a number of environments, it's been very blamey, and people are ruminating, and professionals are ruminating and worrying about whether they're doing the right thing. making the right calls, and take that to bed with them at night, because ultimately they want to do the right thing, and they don't want to be in fear of having done the wrong thing or losing their job or having to go to the regulator and stuff like that.
And we're going to come on to in this conversation maybe some of the ideas that you have and, you know, that are coming through now using technology to make things safer. And let's hold on to that idea, I think, of the shoulder dystocia as an example. We're hearing a lot now about emergency services needing to be more joined up and more connected. What do we actually mean by that? What is a joined up emergency service?
Yeah, good question. What's a joined up anything? We're all talking about integration. We've got integrated care systems, boards, partnerships, and everything else. But for me, integration means that we've got people working together, systems talking to each other, and shared information about patients, and able to work as one, as opposed to a bunch of siloed operations and people.
Does it feel like that now when you're in it? Does it feel like a bunch of siloed operations that are not joined up, that are not connected, that are sort of, you know, coming together but not with the same shared goal? Obviously with the same shared goal in that it's to essentially look after the patient and provide the patient the best care, but does it feel disconnected?
I could ask you the same question.
I'll give an answer after you though.
The answer is yes, it's disconnected. And that's because when people are under pressure, they retreat back to just focusing on what they need to, and their vision and understanding of what's going on outside of their scope goes down, understandably. It's how you preserve yourself. Systems and processes have been commissioned on individual services rather than around the needs of people, patients, service users, whatever you want to call them, our friends and family, you know, that's what people are.
And ourselves. I think people forget that we work in it, but we are also users of it. We're all patients.
Correct.
I think for me as a GP, the feeling of disconnection is this handing over of the patient that we still do. So if I see a patient and the patient requires to be in hospital, the minute the ambulance team arrive, it's almost like I can move on to the next patient now because they're with you, and then you spend that awful, however long it is, handing them over to A&E, and then they go to the consultant, and then, you know, they come full circle. When I receive that piece of paper, that discharge summary from the hospital, they're back with me. And I used to be able to just pick up the phone and speak to the hospital team who'd been looking after them if I had any questions. And that line of communication, it's just not so straightforward anymore. It still used to feel like it was that patient was jointly looked after, but now it feels like, okay, they're back with me, they're my responsibility. And I can only imagine what it must feel like for a patient if you feel like you're being handed over. There should be a continuum of care where everybody, for a period of time, they're still being looked after by both teams, but it's just not like that.
Yeah, it's interesting hearing what you're saying, because I've often thought about the experience that we have as pre-hospital clinicians, which is you turn up to someone, you get an almost unlimited amount of time. Don't have 10 minutes, you've got as long as it takes. You get to meet them in their own house. You meet their family. You pack their underwear and their toothbrush for them. And you take them to hospital and you chat for the 10 minutes or 2 hours, however long it is, on the way to hospital. You build a rapport and a kind of, I suppose, professional intimacy that's often lovely. But it's a fleeting moment. And you turn up to the hospital having kind of built that rapport and feel like an advocate and a champion for them, and you then drop them off having had personalised care at a ratio of at least 1-to-1, maybe 2-to-1, maybe 3-to-1, maybe 7-to-1, and you then dump them into the maze of the hospital where it's not the same experience. And
the doctor that sees them, often a junior doctor, and I've been there, I was that doctor, you are desperately trying to come up with the correct questions, with the right body language to gain that really important information, not about their condition, but about the patient, about their life circumstances, about what life is like at home, that actually you've seen it with your own eyes. You have a very clear picture, because we know that that's so important. And once they arrive at hospital, you know, that knowledge that you have, that connection, the doctors are desperately trying to glean some of that. And yeah.
Well, the whole kind of handover model, there isn't a consistent approach. I was going to say that we oftentimes can't see any of the patient's medical records at all. We're reliant on stuff and ice cream tubs full of medicines, and can't even view in places summary care record or shared care records, even though they exist, can't see them. And the electronic patient records in quite a lot of hospitals have to be printed out and turned into paper. They're not integrated into the electronic medical record systems. And when we do handovers, they're kind of predicated on a major trauma or a major medical emergency resus type handover where everyone listens, and for one moment you actually feel, like someone's interested in what you're saying. The reality is, for most of the interactions, it's a stressed middle grade doctor or senior nurse or paramedic or some other practitioner who's trying to manage the front end, knowing that the back end's completely chocker and there's 40 patients in the corridor and everyone's pulling their hair out, and it's a totally depersonalised, perfunctory handover, which leaves me feeling violated, because, like you say, I've got all this insight and understanding and have no method to be able to communicate it. There is no method to be able to receive it either.
No.
And I guess if we ever had time and space to be able to reflect on it, we could think about how we could make those interfaces better. But I never find out what happens to my patients unless I meet them in Tesco or happen to walk back into the department or chance upon an outcome. And it is what it is in one level, but it's not good enough.